All right, guys, I'm Dr. Wagner, part of SWAC on Murmur MD. Welcome to this month's Angio Club with AccuCinch Transcatheter Left Ventricular Restoration System. This is a phenomenal panel we have. We have great experience with this. So this is SWAC on Murmur MD for May 2025. So my esteemed colleagues in panel include Dr. Brandon Jones at Portland. We have Dr. Mark Benyars, our co-director of SWAC from New Mexico. We have Aidan Rainey and Joe Walsh from Murmur MD, as well as a host of folks from Ancora Heart. So we are pleased to present this and share some of the early experiences in clinical practice for AccuCinch in core heart. So let's get started. Alicia, next slide. So before we get started, I do want to say that this device is investigational, meaning it has been approved for clinical trials. We're sharing content that is published data and or compassionate use cases or roll-ins. So that, without further ado, Brandon Jones, Dr. Jones, please take us away for treating LV dilation in heart failure patients.
All right. Thanks very much, Tom, Mark, Joe, Aidan, for having me. It's an honor to be with you guys. So I'm an interventional cardiologist. I'm a structural heart doc up here at Providence St. Vincent in Portland. And I'm not an advanced heart failure doctor, but I feel like as structural interventionalists, more and more, we are treating heart failure patients. That was certainly true during the COAPT era, and that's been true during tricuspid, functional TR, edge-to-edge repair trials. But here we are kind of squarely in the pure dilated cardiomyopathy space. And so what we see here is our heart failure colleagues, despite, excellent GDMT with multiple randomized control trials showing improvements in heart failure and improvements in mortality with all the wonderful medications we can put patients on, still have very high mortalities at 2 years. And so from the Emperor trial, we see 20% 2-year mortality. And then we all know the COAPT data, even when you treat the functional MR, we're looking at 2-year mortalities almost 30%. So dilated cardiomyopathy, a disease process with high mortality. You can go to the next slide.
And Brandon, that data continues to that curve continues to divide as you know the 5-year data from COAP. I mean, you have patients in the device arm that 60% are deceased and 90% in the control arm. So we know that heart failure, there's multiple mechanisms to heart failure, and there's multiple modalities of treatment. And I think this just is an armamentarium that's additive to this in this sort of patient population.
Yeah. So what's kind of the natural history for a patient in heart failure? So typically they show up with a new diagnosis of a depressed ejection fraction, and there's this rapid initial phase where they're treated. They're put on GDMT medications, and those medications are rapidly titrated, and they may or may not receive a defibrillator. They may or may not be a candidate for something like a CRT device. But there's an initial stabilization for a lot of patients. And then what we see is people get into this phase where you kind of come in with heart failure exacerbations. They might get real sick, and then maybe they can get rescued, and they might get sicker, and maybe they get rescued. But aside from, treating valve disease, if there's functional MR, you consider doing edge-to-edge repair. If somebody's got aortic valve disease, you consider doing something about that valve. Now we have some transcatheter tricuspid therapies. There's a couple like new techniques, including the Barostim and the CCM contractility devices. But really, there hasn't been a lot in this middle phase where people are kind of slipping until you feel like they're so bad that you go to something a little more drastic, like a left ventricular assist device, or even listing somebody for a cardiac transplant. So there's this real gap in between here where is there an opportunity to do something that might actually change the disease process for these patients?
Brandon, this is a fantastic slide. It really is. For the panel, I'd like to pull in Mark Benyars and Joe Walsh. Both of you guys do a lot of mitral TEER. So I'll start maybe with Joe. When you think about mitral TEER, right, in FMR patients, the problem is not a leaflet problem, right? It's still a pump problem. So this to me makes sense why the 5-year data with COAP is as bad as it is in some of these patients, even with the device. It makes more sense to me to fix the pump with an LV restoration device, wait a few months, reassess the degree of MR, then do TEER, then offload the LA with an atrial shunt device. So I think that this is where AccuCinch fits in my mindset. Joe, maybe comment on that as a big mitral tear user.
Yeah, no, I mean, I learned this from Aiden actually, and I think in my functional MR cases, I really try to grab at the level of the annulus and almost perform an annuloplasty. So to that point, it's kind of like a poor man's core cinch in some of those cases. And I find the cases that you get a really good result out are the ones where you can really grasp all the way at the level of the annulus and bring it together. And I think a lot of these patients are dilated, and that's really their primary issue. So yeah, I totally agree. I think that makes more sense. I think we have to rethink the paradigm of
Yeah.
of how we're managing these patients and what kind of interventional therapies are going to be beneficial. I mean, this is a huge ROI for a lot of these medical device companies because there's so many patients walking around with heart failure.
Absolutely. Mark Bernards, what are your thoughts on that? Do you think we have a paradigm shift coming up with how we approach FMR and low EF patients?
So, I hope that you guys can hear me. I just got kicked off. But one of the things that I think it's really important to consider is this is all a continuum of the effects of GDMT, device management, and then more aggressive unloading devices of reverse remodeling. And if you just think along the Frank Starling curve and you overload a heart, a muscle, just like we did in physiology with a frog leg muscle, you load it with weight and then test contractility. And as you increase the load, the contractility just disappears. And so what we're doing is again and again and again, reverse remodeling this muscle to get rid of the fibrosis and actually improving the function of the muscle. So, I mean, you're totally right. We're doing much more with every single therapy than just simply treating the focused thing. We're not treating necessarily the blood pressure. We're actually reverse remodeling with GDMT. So it's an important baseline thing to think about the cardiac physiology as we're going through these different interventions.
Excellent. Very good. Back to you, Braden.
All right, let's go to the next slide then. So what is kind of the hypothesis here with regards to modifying the left ventricle size? And so this comes from basic physics, and like Mark was saying, we talk about the Frank Starling curve a lot. It's one of the first things you learn in medical school. And we know that the more the LV dilates, the more wall stress there is, and that has effects on pressures inside the LV. And so is there a way to reduce wall stress as the therapeutic target rather than as a direct target rather than doing things like modifying sympathetic tone with medications or stimulation, but actually just physically targeting the walls themselves? And so this is a depiction of the AccuCinch device. And so basically it is a transcatheter device that's aimed at directly targeting the left ventricle. It's supposed to reduce LV size, and that reduces stress on the LV. And then that initiates a process that we hope leads to biological reverse remodeling. And our goal, obviously, with these heart failure patients, try to improve their quality of life, improve their functional capacity, try to reduce heart failure hospitalizations, and ultimately, if we can avoid mortality associated with heart failure or progression to things like left ventricular assist device or transplants, which really have known limitations in terms of life expectancy when patients have to cross over those more severe therapies.
Brandon, I have a question for you. This is it's a fascinating device, and a fascinating concept that's been that has had multiple trials that have tried to actually affect what we're seeing with this device. This, as you see from your diagram here, this is one spot in the myocardium that's being pulled in. I've kind of described this as changing the fulcrum of the contractility, kind of like a lever. But what are your thoughts in how this device actually affects, as your arrows show, this reverse remodeling of the entire myocardium?
Yeah, I guess I don't know, what would be the perfect spot to try to pull the ventricle in, and if you could do it in multiple spots, would that be better than one spot? If there is a certain amount of mitral regurgitation, are you really wanting to target something closer to the mitral annulus? I don't know. I think those are really interesting questions, but I think in some ways this was the most logical spot to try to target first. the device was initially kind of developed as a mitral regurgitation reduction device. And I think that had a lot to do with initial development and figuring out how to develop the catheter and where the implant was going to be located. Obviously, the pivotal trial that has been pivoted to is one that treats patients with 2+ or less mitral regurgitation, is more kind of a pure dilated cardiomyopathy trial. But it does, anecdotally, we'll show some data from the early EFS, but there does seem to be a global improvement in left ventricular function and size just from targeting one location.
Yeah, that's fantastic. Aiden, let me reach out to you. I know you're a high-end, high-volume end user with interventional structural heart. When you see this device and you think about the approach to it, which we'll get to, being retroaortic, and to Brandon's point, it's placed, 1 to 2 centimeters below the mitral annulus, and that's where the CT analysis is critical to understanding where it's going to go in. When you see this sort of device going retroaortic, does that have any concerns from a procedural technique approach?
I don't think so. I mean, not any more than transeptal and going through the valve. I mean, I think obviously you probably have to be a little careful with the aortic valve, but yeah, I mean, I think we do it with TAVR, right? We put a lot of stuff across there, and I think it makes a lot of sense to approach it that way.
Yeah, I agree. And Brandon, for me, this is like the next frontier in interventional structural cardiology. 20 years ago it was crossing a tight aortic valve to do a TAVR. 10 years ago it was doing a transeptal for a mitral clip, and now I think it's doing retroaortic LV looping. There are multiple companies now that have devices out. Obviously, AccuCinch is one of those. HighLife, the TMVR system, has a ring placed similarly. You have transeptal TMVR systems with M3 and Tioga that also require LV looping to some degree. So I think this is the next skill in our skill set to understand and learn to master.
Well, if you think about the devices that just dwell across the valve, I put in with our surgeons a 5.5 the other day, and we're all adept at putting in the CPs, but the 5.5 is a huge device,
Yeah.
and we can keep it in across the valve for 30 days. So yeah. I don't really have any hesitation with doing an intervention across the aortic valve.
Excellent. Very good, Brandon. Let's finish up the slides here. Fantastic.
All right, so we got a little video here kind of showing some of the procedural steps. And so, like you guys said, it's a large bore access. It's a 20 French gore dry seal that we use initially. And you come across the valve and you place a series of anchors and spacers. And then the last step is cinching the device up to provide tension across that whole system. And so what we're seeing here is kind of a depiction of pre and post cinch. So that pink line, so this would be an LAO caudal view. You're kind of looking down the barrel of the heart, and you take a picture with all the anchors and spacers in before you tighten it, and then you apply tension gradually on the device, and all those little spacers start to line themselves up, and the anchors all line themselves up. And what you see is this acute reduction in diameter.
That's fantastic. Very good. Okay. Next slide.
So I think they're going to have us go quickly through the, sort of the EFS stuff, Tom, if that works.
That sounds great.
So, so the published data, obviously we don't have any of the data back yet from the pivotal trial. They just hit 250 randomized patients, which is the first landmark analysis for the pivotal trial. We're going to need to finish 6 months follow-up, and then that'll give us our first peak and potential submission to FDA. The full randomized cohort is going to be 400 patients out to 1 year. But what is published and what we can talk about is data from the early feasibility study. And so this is information on 51 patients that were treated at a number of sites during EFS. Ejection fraction is 20 to 40%. These patients all had 2+ or less mitral regurgitation. And like I talked about, the device was, the determination was we were going to focus on a pure dilated cardiomyopathy cohort because that seemed to be the most needy cohort. There's a lot of technologies out there targeting mitral regurgitation, but nothing targeting pure dilated cardiomyopathy. And then they looked at safety endpoints and efficacy endpoints. And so these patients were in their mid-50s, mostly male in the EFS study. They had mostly non-ischemic cardiomyopathy, 25% were ischemic, and the usual comorbid conditions, mostly class 2 and class 3 heart failure. Average ejection fraction about 30%, and again, a variety of moderate or less mitral regurgitation. Importantly, these were pretty dilated hearts, and diastolic diameters 6.6, at large volumes.
This is remarkable, Joe. When you look at this, are we potentially intervening on someone's life here? The natural history of a 55, 56-year-old with a dilated cardiomyopathy of over 6 centimeters. I mean, the life expectancy for that cohort is dismal. So what are your thoughts about this? I mean, usually we see patients with TAVRs or MTIRs and they're octogenarians. These are folks that are in their mid 50s, not much older than some of us. So, do you think this could potentially be that paradigm shifting strategy you talked about earlier?
Yeah, well, I mean, it's certainly an unmet need, because we see these patients all the time referred for TEER, and we all kind of quote the mitra coap discordance in the dilated ventricles, and so I think this is certainly an unmet need for heart failure therapy. It is interesting how young they were,
Yeah.
I mean, and it'd be interesting to see also the background of goal-directed medical therapy. I don't know if they have slides on that, but it'd be important to make sure you work with your heart failure colleagues really on a coap level of making sure these folks are all optimized with resynchronization and GDMT.
Yeah, I think this is remarkable. It's really striking me. The average age of 56 with LVDDs of 6.6. I think that sort of population left untreated without adequate GDMT and or an LV restoration like mechanical device. It's not good. It's pretty dismal. So, fantastic. All right, Brandon, let's move on to the next slide.
Yeah, so just to answer Joe's question about GDMT, yes, these patients were all on maximum GDMT. The EFS closed in 2021, so this was sort of pre SGLT2I inhibitors being part of the routine treatment for these patients, but obviously that's part of the pivotal trial now. And so looking at safety, so this is out through this is acute safety. So related to the device itself. So no procedure-related deaths. There was one late stroke at day 7 in a patient that was it was a anticoagulation issue. They thought an AFib patient, and no MIs. There was a single case where there was pericardial effusion, and we'll get to on some of the sort of procedure walkthroughs how the procedure is actually done, but it involves puncturing all these anchors into the heart. And so, those of us that are on the trial, we've all been to one of these animal labs where you have to do a couple cases on sheep to try to get a feel for the device. And when you first do it, you're like, my gosh, we must cause effusions every time we do this. That feels like such a crazy thing to try to do. And I was like, good thing it's a sheep. But then you do it and you're like, wow, that went fine. And then, you get a couple real cases under your belt and you're like, it's very repeatable. And here you have proof that, 51 of the very, very first cases, there's only a single pericardial effusion. So I think that's the most important safety marker. And there were a couple femoral artery access site issues early on, mostly related to some European sites that weren't using any pre-closure devices for these 20 French systems. So
that's also remarkable. I agree with you, Brandon. That when you see the anchors are 5 millimeters, you need for tissue. Mark Bignor is when you first did your first case, to Brandon's point, what were your initial concerns?
So I was gonna say basically the same thing. Doing it on sheep, it's live, beating heart. You're implanting the device into sheep. You do 2 back to back. I have to compliment the preparation that we had for this, because that made all the difference in the world. You can do as many simulations or as many device deployments and models, but until you have live tissue that you're deploying it in, you don't get the same feel. But it was actually pretty accurate. You get a feel for the equipment, but you trust the protocol, and then you trust this EFS data to then take it forward confidently into a human. And it was almost seamless, but it's still that first anchor that you deploy into a beating human heart in somebody that you've bonded with over all the time getting enrolled in the trial. It's disconcerting, but you have all the reassurance of the device design and the protocol. So I mean, it wasn't terrible, but you still have to do it.
Yeah, exactly. Fantastic. All right, Brandon, let's have you go. Proceed.
Yeah, and then this is kind of the really cool part is that you see an initial change in ejection fraction. So you get the cinch, the heart comes in, you get immediate improvements that sometimes are seen even post procedure day one, and you get an immediate reduction in LV volumes. But then to look out to 2 months and see what happens over time, you get this sustained reduction in volume, and then the improvement in ejection fraction actually goes up the farther and farther that you look.
Isn't that amazing, Joe? When you see that, I mean, it's pretty remarkable. To Mark Bernard's earlier point about the Frank Starling curve being shifted, I mean, this is pretty encouraging early on.
Yeah, no, I've been fascinated by, the hemodynamic effects of a lot of structural intervention we do. And Nicholas von Meegen's doing some really cool work on pressure volume loops in TEER to identify responders or non-responders.
Hmm.
Because we all know these patients, especially with MR, have this contractile reserve issue that we talked about ad nauseum in the aortic space. But, when you're significantly increasing afterload with TEER, some patients' ventricles just fall apart. So I'd be fascinated to see if Ancora or anybody has any sort of pressure volume loops on what happens when you actually cinch this thing down in terms of the LVEDP and stroke volume and cardiac output and stuff. Because you don't have that kind of acute afterload increase that you have with TEER with this.
Yeah, absolutely. Very good. Brandon, back to you.
All right, so just a couple more endpoints from the trial. So, we saw significant improvements in KCCQ 12 questionnaires, 19-point improvement out to 24 months. That's on par or better with some of the results that we had seen from some of our tricuspid trials recently. More than 80% were class 1 or class 2 New York Heart Association at 2 years, and good 6-minute walk improvement. So there are some good endpoints that there were improvement in symptoms and quality of life for all these patients. Again, single arm, this is only, the treated. We don't have a randomized comparator group here, but 90% survival at 2 years is better than all that data that we showed on the first slide for what we would think the natural history would be for these types of patients. Only 5 deaths out of the 51 patients out to 2 years. Only 3 of them progressed to needing left ventricular assist devices, and no patients that needed a heart transplant.
That's remarkable. I mean, 3 needing LVADs out of 51. Again, I think the natural history, if you went back to your first slide, not that you need to, but these patients don't do very well without mechanical support. GDMT works very well, but there are side effects to it, which we could spend all day talking about: renal failure, hypotension, nausea, GI, you name it. So I think this is pretty remarkable to me to see, the time to all-cause death, 90% survival at 2 years in a population that usually, with historical data points, doesn't do well without an intervention.
Well, and if you think where this device is sitting in heart failure treatment, I mean, these are people who have maximized their standard therapies, who are going towards a definitive therapy, a durable VAD or transplant.
Yeah.
And that puts this in context here. I mean, this is incredible.
Aiden, when you see this, there aren't many devices we do that have 90% survival rate with that sort of low EF. Maybe talk about your experience with TEER in low EF patients relative to something like a CoreCinch device.
Yeah, I mean, I think, obviously we all start with GDMT, and, I had a patient today and her MR completely went away with GDMT, but certainly there's a lot of these patients, you can't get them on much GDMT based on, renal function, blood pressure, et cetera. And, even if you do, they're usually not at full doses. You just can't really get them there. And, these patients don't do very well. And, I think the clip is helpful in, a lot of these cases. We have data for that. But, obviously anything else that can kind of help the ventricle and, help get more GDMT on, I think this is pretty impressive, the 90% survival.
Yeah, the unmet clinical need, back to Joe Walsh's point earlier, I think there's a huge cohort in the slide that Brandon showed. I think really kind of teases out all the therapies that are out there, and when do you pick the right one is the question. So, Brandon,
Tom, I
back
have
to
a
you.
question for you because you're kind of in touch with the regulatory space more than anybody, I think. Like, I think there's a lot of haters in the tricuspid space because we're getting FDA approval based on quality of life metrics, and say what you will, I think patients do a lot better without tricuspid regurgitation. But like, has this set a new standard for FDA approval on some of these interventional devices? Because interventional heart failure is still kind of a little bit gray in terms of how we're going to achieve FDA approval and reimbursement decisions for these. Like in 2025, is KCCQ and quality of life enough to get FDA approval? Like, I mean, because this is we're used to looking at like MACE rates and mortality and stroke curves, and like looking at a KCTQ, I'm like, I don't freaking know that. I don't know what that means, right?
Yeah.
So what is your opinion on regulatory approval processes that involve quality of life?
Yeah, it's a great question. I think Triluminate kind of hopefully set the standard and created less ambiguity for the need to get these devices approved, particularly in a space, to your point, where there's an unmet clinical need. So if you're competing with a commercial device, I think it'll be much harder and the MACE rates will be required. But when you have a device and in a space that has a large unmet clinical need that needs to be treated and there's low risk of major adverse events, I think this could potentially be pushed through with very little regulation required.
Well,
Brandon, what do you think of that?
honestly, frankly, it's a matter of perspective, and we have to be able to give the pushback to our colleagues who are naysayers. I mean, orthopedic surgery is an entire field that's based on KCCQ improvement.
Yeah.
Right.
Yeah.
So, I mean, it's a matter of patients who are dependent on diuretics to leave their house, or they can't leave their house, and if they then can leave their house and go back to work, I mean, the economic benefit to the city is huge. And it's a new paradigm for cardiologists to think about non-MACE related outcomes.
Totally.
Absolutely. Good points. All right, Brandon, let's move on here. We're getting late in the hour. We got some cases to go. Shoot, it sounds like.
Yeah, just like one other hard endpoint. So there was a significant reduction in annualized heart failure hospitalizations. And, I will say Triluminate did eventually show a reduction in heart failure hospitalizations when we did the 2-year data that was just released at ACC. So I think some of that stuff, it's still important to go after hard endpoints to answer your question, Joe. But I do think quality of life is paramount to patients as well. And yeah, so that's the early feasibility study. Pretty good safety signal, clear signal, at least in this small subset for efficacy, and we're just really excited to get a look at the first 250 patients coming up here in about 6 months.
That's fantastic, Brandon. I tell you, it's exciting to see this, and I'll let you go through this slide here, then we'll move on to a couple cases.
Yeah, this basically just kind of describes the trial as we're doing it now. And so it can be ischemic or non-ischemic, EF's 20 to 40%. These are dilated ventricles. You have to be greater than 55 millimeters end diastolic. And again, we're looking at 2+ or less MR. All these patients are adjudicated by a screening committee with heart failure doctors, and we really target maximally tolerated 4-pillar GDMT. If they need a CRT device, that should be utilized. If somebody does have MR, they can have a TEER procedure and then be enrolled subsequently, and they should be symptomatic. So 100 sites enrolling in this in US and Europe, and so there should be a site somewhere close to everybody where you could refer somebody to be considered.
That's fantastic. You can move on to my slides. I just have to comment, guys. I mean, we have 5 or 6 interventional cardiologists, talking about heart failure here for the last 30 minutes, and another 30 minutes still. It's exciting, and this is that's why I love our space. There's always something new and some new technology. So, very good. I'm going to breeze through some procedural planning and some overview. Then we'll jump back to Brandon's case, and then Dr. Bernardo's to close out with his case. So, next slide, please. So what you look at on CT is a full cycle, all phases, and what you really want to look at is 1 to 2 centimeters below the mitral plane along the LV free wall. So at 10 millimeters, at 15 millimeters, and at 20 millimeters, to make sure you have at least 5 millimeters or greater wall thickness. As you implant the screws, the anchors can be, you can put 13 to 15. It really varies depending on the anatomy. So that's really key. So about 5 millimeters of healthy tissue. And you want to look at 10 millimeters, 15 millimeters, and 20 millimeters below the mitral plane on the LV free wall. Next slide. So Access, it is a large bore system still. I'm sure there'll be iterations down the road once it's commercialized where they'll get smaller French saws like everything else. The key right now is to prove that it works and it's safe. So you need compatible vessels for 20 French or an 18 French guide. So 5.5 to 6 millimeters is critically important. Next slide. The system that Brandon described nicely and had a nice animation, it's really three parts. It's access, delivery, and then the cinching. And the access is, again, retroaortic. You have an 18 French system across the aortic valve, very similar to High Life TMVR system. Very similar technique. You have a nav cath that navigates around the LV behind the papillaries, and then you go through a track cath system inside the nav cath, essentially to bring your guide around, and then you create your cinch by bringing in your sliders and spacers. And again, the number can vary depending on the dimensions and the anatomy of the LV. Next slide. So this is the navigation within the LV chamber. This is the deployment of the anchor, spacer, anchor, spacer, anchor, spacer cadence until you fulfill your geometry. Again, the ones we've done have been 13 to 15 anchor spacer combinations. And Brandon and Mark, maybe comment briefly on yours. Do you know how many you've used, and did it make a difference?
Yeah, I think you just kind of use as many as the ventricle will accept. I mean, obviously, you can't get too far around because you start to head back out the LVOT. And so you kind of get a sense based on the size of the LV, how many windows you're going to have available to you to go and put anchors and spacers in. And I think, you want to get as much of the circumference of the heart as you can to maximize the mechanical changes that you're going to see. The case we did on Tuesday, actually, there was a lot of trabeculation, and there was one PAP that we just could not wire behind that was right at the mouth of the guide catheter. So we actually stopped the implant one window short to avoid causing some mechanical disruption in the mitral valve at that commissure. And so there is some, you can tweak it a bit if you need to.
Fantastic. Yeah.
Excellent. Well, and it is pretty amazing that this is not an entire ring.
Yeah.
You're going around half of the ventricle here, kind of commissure to commissure, if you see the image on the mitral valve. And then once it's cinched, it almost becomes it's almost straightening that ring, so it's a short segment of myocardium that has a lot of effect.
Yeah, excellent, Mark. And then you cinch and create this uniform LV reduction. It's remarkable. So here's the case. So access and wiring left ventricle, your guide's placed in a retrograde fashion across the aortic valve. You want to be mindful of any baseline AI or any aortic valve pathology. You do your injection, and then you have your nav cath, which navigates around and facilitates that LV chamber wiring behind the chordae. And then you can see on short axis T image there that you're behind the chordae. You can do a practice cinch to make sure you pull in and you're in a good spot. Next slide. You can advance the next slide, Alicia. This is it seems complex, but with the nav catheter and the track cath, I think it is pretty smooth. It doesn't take, from a technical standpoint, it's not a skill set you're used to, but again, I think this is the next frontier in terms of interventional structural. So here's the indicator wire. There's the wire in the anchor deployment. Then you have your track cath, which allows you to advance an anchor and then a slider and then an anchor and a slider until you fill up, back to Brandon's point, as much as you can to adequately create that C shape. So when you cinch it, you can pull in more myocardium. Next slide.
Hey, Tom. The indicator wire is very important for assessment of depth because it basically is going out the side of the anchor deployment catheter, and it tells you when you're even with the myocardium and then advancing it, and you're looking for that thing to double over to have an absolute predictable depth of deployment. I think that's kind of an important highlight of that.
That's a very good point, Mark. So Mark's absolutely spot on. When that wire bends like a little flag and bends down, then you're at an adequate depth in terms of firing the anchors. So then you implant lock and your slack's added back, and you can see a little bit of slack given back, and then we'll do our cinch there on the final image on the right side. Next slide.
Be nice if it was like braces where you could bring them in and like tighten them every 3 months.
Hey, one day with Bluetooth, you might be able to do that. Honestly, from your phone and say, "Hey, LV dimensions on CT at 12 months. I need to modify this." So you add Bluetooth sensor to it, and you can potentially do that. So very good, Brandon Jones. Let's discuss your case, my friend.
All right. So yeah, I think, the case we can go through quickly and then we can just sort of talk about some of the nuances of the procedures. But so this is a crossover case we did. Obviously, we can't talk about anybody that's randomized in the trial, but somebody in their 50s, ischemic dilated cardiomyopathy, class 3 heart failure symptoms, hypertension, hyperlipidemia, prior smoker, some lung disease. And you can see on all the good medications, Entresto, carvedilol, spironolactone, SGLT2I. He's on diuretics and having trouble with hypotension with the medications. Pretty common problem with our heart failure patients. We put them on all these things and they sort of like skirting the trees. And you can see mildly elevated creatinine. Ventricle is dilated almost 6 centimeters. And ejection fraction is kind of hanging in there at 34%. And actually, initially got randomized to the GDMT arm, to the control arm, but then crossed over at 2 years. And so just like Tom was saying, initial efforts, you got to get this track cath in and wrap around the chordal apparatus and make sure that you're behind it. And, to your point, Mark, about the wire, initially it seems like kind of like a low tech kind of solution for trying to figure out like how deep to implant. And I kept thinking like, oh, there's got to be like a higher tech, like automated way to do these implants. But what I've kind of come to realize is that it's actually extremely tactile and it doesn't require that track cath to be in exact contact with the myocardium. So you actually have some wiggle room. If there are points where you're really jammed up into the myocardium, you get a signal right away. There are points in the implant where you actually have to travel a little bit away from the track cath in order to contact the myocardium. You're flexible in all sorts of different situations in order to make sure that each anchor goes in at the right depth. And it's extremely repeatable and it seems to be extremely safe. So I feel like I've kind of eaten my words on sort of my initial impressions of that type of solution for gauging depth.
Is this at all, Brandon, is this at all like like in terms of compared to SM3, is there any overlap in terms of the technique, in terms of the wrapping the dock?
In terms of like how you initially wire?
Yeah.
Well, so I'll say I don't have personal experience with that technology, but the guide will direct you into the subvalvular space on the mitral initially, and so you can actually, there's a little thing that you start to unscrew, and it flexes the guide up under the mitral valve, and then you place this nav cath, which has a little directable tip at the end, almost like a 45-degree angle, and then use a baby J wire. And you go into a steep areocrany, and you can see, if the wire starts to dive down towards the apex, you adjust and you turn your nav cath. Sometimes you can cross up into the atrium and you adjust and you do the nav cath. And eventually it just tends to wrap around the subvalvular space and then back out the aortic valve. Obviously, you need your TEE doc to spend some time there and assess all the different angles and make sure that you're not pushing a cord down or a papillary muscle down. But I was a little stressed out about that part of the procedure too. And I think that our TEE support cardiologists feel like it's a much easier TEE than the ones they're doing for tricuspid clips and TTVRs. And so
it is, Brandon. I'll just dovetail off your comments, Joe. Having done M3, I can tell you, I think having done M3, high life, and AccuCinch, I think doing retroaortic actually is a more straightforward LV looping approach rather than dropping below the annulus from an atrial side and trying to do a counterclockwise 3-doc or 1-doc system. As I was alluding to, I think this is going to be easier and more mainstream once they have smaller systems. Obviously, 18, 20 French systems across the aortic valve is not something we want to have as a workhorse system. Eventually it'll be smaller, maybe 8, 10 French. But I think the angle of approach is easier, and I think LV looping, you could almost do most of it on floor if you have a good CT as a reference. So for like high life, we'll have 4 views on CT, and we do most of it actually fluoro based.
On the guide, there's multiple different guides. They choose a guide based on CT images, which makes it pretty straightforward then, because the the flexing of the guide under the mitral valve is planned out. And so, and I have one case that I've done, but it was not difficult to navigate underneath the mitral valve, at least in my case.
Excellent. Brandon, go ahead and proceed.
All right, so just to show a little bit what it looks like, initially it looks like the spacers and the anchors are a little bit, haphazardly placed, but it's kind of amazing how they all just like get themselves lined up when you start to cinch the catheter and cinch the implant. And then it's designed to release a little bit of tension into the implant after you do the final lock, so that the gaps that you see, the slack on the image on the right, is intentional and allows just a little bit of relaxation of the device. So we had a 7.4 millimeter acute LV reduction just inside the case.
Remarkable. Excellent. Okay, I'll jump into my case and we'll have Mark close it out for us. Very good. So next slide, Alicia. This is, again, a trial patient, so I will say 65 to 70-year-old male, ischemic dilated cardiomyopathy, class 3, has been hospitalized about a year and a half ago. ICD, you can see CD with LD PCI. This is one of the gentlemen, to Joe's point earlier that we were discussing. He's was in his early mid 60s, had a massive MI, late presenting anterior STEMI. This was a couple years prior to this intervention, and got the LAD open, got a great result, but just LV was infarcted and never recovered. So he was on, optimal GDMT. Is Jovi Velasco on? I'm not sure. If you can make sure, Zach. Excellent. Jovi's there. Perfect. So Jovi is one of our local heart failure specialists that has been phenomenal in screening these patients and looking them over. Jovi, when you look at the medications here, when I look at this, at least, heavy doses of Entresto, 97-103, metoprolol 50s on Jardiance, spironolactone. Patients have a hard time tolerating some of these meds. Maybe comment on, from your approach when you see this, how do you approach a patient and what do you talk about? What are you looking for when you do GDMT?
So yeah, so symptom-wise, so it's usually a lot of times it's the hypotension, the dizziness is what they're talking about. The dizziness, I don't really worry about it that much, and I tell them that these are expected side effects from your medication. Depending on how much they can tolerate it, I would lower the dose if needed. But the thing with the GDMT is it does not only focus on the 4 pillars of medication. You can also use other medications like vericiguat, isosorbide dinitrate with hydralazine to get them optimized. So for example, if you have difficulty getting them on target or maximum dose of sacubitril valsartan because they have problems with their kidney function, then you can potentially still use other medications to optimize them.
Excellent. So at what point do you decide, hey, this is maxed out? Is it, the hypotension less than 100, less than 90, we have patients down in the 80s sometimes. From a blood pressure standpoint, obviously maybe relative to their EF, what's kind of your cutoff?
So with my practice, I usually send them back to the cath lab just to make sure that their pressures are actually better compared to where we started. And then obviously we're going to check their 6-minute walk test again and KCCQ if there's any improvement with that. If we feel, and then I would ask the patients, do you feel like we have more room to improve to get you to feel better? If they say they do, then I would try to do to include more therapies if needed, or maybe add other interventions that would require devices.
Excellent. How about maybe comment on, you mentioned the cath. So doing a right heart cath, is there a bigger role for devices like CardioMEMS? There are some patch devices. There are new technologies coming out in trials to monitor LA pressure, LAP and wedge non-invasively. Is there a bigger role, you think, in the future for that sort of technology?
Yes, I definitely agree with that. I am a big advocate for CardioMEMS. And to be honest, in my experience, putting CardioMEMS on patients actually helped me optimize their medications better and faster. Just because every time I change their medications, I would see immediately what the changes it does with their pressures.
When
Yeah, and same thing. Sorry.
I'm sorry, dear. In the absence of doing a right heart cath clinically, how often do you see them back to gauge clinical effectiveness?
So I usually will ask patients to come back every 2 weeks with me. If I have, so where I practice, there we have a clinical pharmacist who I would ask to at least call the patient, check symptoms, blood pressure, weight, how they're feeling symptoms wise, every week. And then every 2 weeks, I would like to take a peek at them and see how they're doing overall and see if we can push further.
Excellent. Great points. Great points. Okay, Alicia, let's move on. Next slide. So here's our device deployments. TrackCath, again, back to Brandon and Mark Bugnaro's discussion. It's relatively straightforward. The guide angle is set. You have a TrackCath around, you wire around, and then bring your system in. Your indicator wire, to Dr. Bugnaro's point, is key. And to Brandon's point, it is. I mean, it seems pretty simple and arbitrary, but it actually is. The tactile feedback is pretty reliable. Next slide. So perfect. So here's the pre-cinch. Again, as Dr. Jones showed, you have complete cinch in the middle, and then the end of the procedure, you had about 9.5 millimeters of slack reintroduced into the system. Next slide. And here's our device procedural result. You can see post-procedure in the green, pre-procedure in the pink. He had 8.6 millimeters of acute LV reduction, about 2 centimeters below the basal plane of the mitral valve. So this is pretty remarkable. This patient went on and did very, very well. We were able to reduce and de-escalate his GDMT over the course of about 6 months to a year, and is doing very well. Next slide. Excellent. Dr. Bugnaro's, take it away, my friend.
All right,
Hey,
great.
Tom and Brandon, do you guys any like post-procedural kind of tips and tricks in terms of managing these patients? Like, do you aggressively diurese them if their filling pressures are up? Like, what are you doing with their right heart numbers? In terms of like post-procedure management, any nuances that you guys have found?
Brandon, I'll let you take that one.
Yeah, I mean, I was just listening to Jovi and I was like, man, is there a harder working subspecialty in all of medicine than the heart failure team? So I will admit that I do the implant and my heart failure team is just all over these patients. I think, one comment about intraprocedural stuff. So we were supposed to do a case on Tuesday, and the patient came in and you could tell there's more MR than we were expecting to see, and the wedge was higher than we were expecting to see, and index was lower than we were expecting to see. And we were worried about, is that patient going to tolerate the procedure as is? So we put him in the hospital, got him on some inotropes and a LASIK strip, and you got the ventricle down, you got the MR reduced. And the procedure that we ended up doing today actually was really much more well tolerated. You do get a little bit of AI from the guide catheter going across the valve. You have to watch it. You can adjust the catheter position and get it into a commissure in the aortic valve and do some things to sort of adjust for it. But the case today, we in the case, you started getting a lot more MR, and that's one of the things you have to watch for is, are you causing any chordal interactions? But we were confident that we weren't. And by the time the cinch was done and we removed all the equipment, the MR was like trace to mild. And so, you do have to watch out for acute procedural hemodynamics. And I'm just glad we have people like Jovi that are, doing all this really frequent touch points with these patients that they need.
Yeah, many trials actually that are coming out, from what I've heard through the grapevine, are going to require a lot more intense GDMT. It's not just going to be coapt; it's going to be like coapt on steroids for some of these valve trials. So excellent, very good. So Mark Bugnaro's, please take us home, my friend.
Well, and just on the GDMT front, it's important that as we as structuralists discuss this stuff. I mean, I love this discussion right now because we've just continued to go back to GDMT as very, very important baseline therapy. We have to be the advocates for this. It's very easy to put a mitral clip in somebody, but it's very hard, and it requires a lot of intense discussion to actually get them onto appropriate therapy. So this patient is I'll just say 45 to 50-year-old African-American male who is actually randomized to the pivotal study. He was randomized to device therapy, and he has a history of non-ischemic cardiomyopathy with 2 prior hospitalizations in the last year. He has an ICD that was placed for an episode of actually VFib, requiring resuscitation. And the drivers of his heart failure probably was terribly controlled hypertension, and he was an obese man. He owns a catering place called Fat Daddy's Catering, just to give you the perspective there. So when I first met him, we were just talking about soul food the whole time as I was doing his initial cath. He has, of course, sleep apnea. He was well controlled actually on extremely high dose of medications, just to give you an example of where the medications can go to. So on the 4 pillars, as well as combination nitrate hydralazine, and doing adequately well, but still with a lot of symptoms and heart failure hospitalizations despite maximization of his GDMT. Um, the interesting thing, and instead of showing the images, I just wanted to talk about this patient and some of the highlights of having a patient that enrolls in a trial. When you have somebody and you've done everything that we can do, you really do need to have a meeting with them, and they need to be 100% on board and actually asking to be enrolled in a trial, with complete understanding that this device may or may not be what they get in the trial, and it also may or may not be effective. And it's very important to have that equipoise with presenting a trial to a patient. And so this gentleman wanted to be involved in this trial more than anything because he was grasping at straws. He knew that the next step would be enrollment, or I'm sorry, would be placement of a VAD. He was excessively obese for transplantation, but still could possibly be have transplant. And I don't know if we have any other slides with this, but I can talk about the outcomes that he had just personally from the device implant. The device
Alicia,
implant was.
do we have another slide real quick for Dr. Bernardes? I think that was mostly just going to be discussion.
Yep,
I
this
think
is the last
that's it.
slide.
Yeah, go ahead.
The device implant was uncomplicated. And I explained this to him as we were, that's kind of like making a necklace, and you just put the beads on the necklace and then push the beads to the end of the necklace. And that's kind of how I've described this to multiple people. And then the cinching is like taking the hood of a winter coat and pulling on the little locking device, and that shrinks down the hood of a coat. And I think those have been very helpful for people to understand this, including this guy. And he had some chest pain afterwards with an enzyme elevation, because of course your hospitalists want to check troponins after you've implanted anchors into their myocardium. And so he then had a little bit of a prolonged hospital stay because of the elevation of his cardiac enzymes. So that's just to highlight that you're going to have troponin elevation after you've disrupted the myocardium like that. We did an echo the next day. He was doing perfectly fine. And he returned to the hospital with some more chest pain, but was feeling very, very good. The day after getting out of the hospital, he walked 2 miles. And he hadn't walked. He was debilitated with his heart failure before, and he said it's remarkable. My shortness of breath has improved, and I'm able to walk. And then his chest pain finally resolved. Probably some inflammation from placing the anchors. And then he is now regularly playing basketball with his son, which was something that was unheard of for this gentleman in the years leading up to the device placement. He actually yesterday went with his 5-year-old to kindergarten graduation and sent us pictures of that. So it's really important to realize that these people, you end up kind of living life alongside of them as you get them enrolled in trials. And it's very important that we believe in this device. I think it's a good lesson from this entire discussion that everyone on this call believes that what we're doing with enrolling patients is beneficial, and we believe in the therapy, but we don't know, and so we're very excited about this trial. So those are kind of my parting words on behalf of this great guy.
That's fantastic, Mark. That's fantastic. We're getting late in the hour. Let's just go around and do final thoughts. Mark, that was wonderful. Let's go to Joe. Joe, maybe give your final thought about the CoreCinch device.
Yeah, no, I think this is I think this is great. It's nice to have options for these patients that find themselves in kind of no man's land between advanced therapies like LVAD and transplant or valvular heart disease. Like all these therapies, I think it's going to need a good pivotal with some solid outcomes and a good reimbursement decision. Because at the end of the day, 131-minute cases, which I'm sure will get shorter. A lot of these new technologies live or die by the reimbursement decision. And it's unfortunate, but it's just the reality. So I'm excited about it, and I really thank Brandon and Mark and yourself, Tom, for sharing this technology. I think it's important everyone knows what's coming around the corner.
Excellent, excellent, Joe. Thank you. Aiden, final thoughts.
Yeah, I mean, I'm really excited to see the data. I mean, I think all had, heard of cases where it's pretty, amazing, change in the patients, but we're going to need to see the data. And, honestly, I think it's going to become a big challenge for us to figure out which patients we use it in. Obviously, if they got rid of, they didn't include the severe MR, so I suspect we'll have to treat MR first, maybe with TEER. But we're going to have a lot of tools in the armamentarium. We're going to have, we have everything from cardiomems to TEER to these devices. So, I think it's going to be, hopefully the data will be good, and we'll just have to figure out when we're doing what. So looking forward to it.
Excellent, excellent. Let's jump to Jovi, then Brandon, you'll give us your final thought to close this out.
Yeah, I am very excited about this technology. Yeah, because I think this is going to be another option for patients, especially those who will not be possibly a candidate for a heart transplant. Yes, they can. Some of these patients can possibly be a candidate for LVAD, as we can see in the discussions today, that some of these patients actually get LVAD eventually. But I think this is still going to be a bridge for these patients because who knows how long before they can become a candidate, or maybe they will not be a candidate at all for advanced therapies like transplant and VAD.
Excellent, excellent, Jovi. Brandon, let's close it out, my friend. Give us your final thought on the AccuCinch system.
Yeah, I would say, we don't have the data from the pivotal trial yet, but I'm extremely hopeful because this is a group of patients that really doesn't have a lot of options and dedicated devices for treatment. And so, we all have to reserve judgment until we see the final sort of pivotal data. I'll say, we've done 7 implants now at our center, and what I can say is it's surprisingly reproducible. I think it's very teachable. It's very learnable. It's anecdotally, it's felt like a safe and controlled procedure. So I think it is disseminatable, assuming that the data is as good as we all hope it will be. And I just love this emerging field of even further collaboration with our advanced heart failure teams, where we're doing structural heart failure combined care for these patients. Really exciting sort of next phase for the structural community.
Yeah, well,
That's fantastic, guys. Well, listen, it's been a wonderful session, a very educational session for us in interventional heart failure. I want to thank our colleagues and panelists, guys, on behalf of SWAC on Murmur MD for May 2025. Thank you very much. Have a great night.
Good.
Thanks for having us, Tom.
Cheers. Thanks, everybody.